Hello everybody and welcome to this week's episode of Medisodes. This week we're going to be talking about using technology in the treatment of heart disease, and this is a follow-up of our episode on heart disease as an overall topic. Be sure to check that one out before this one. To kick us off, I'll hand over to Anupam, who will be talking about cardiopulmonary bypass and its importance in surgery.
Cardiopulmonary bypass is the main way that heart surgeons have been bypassing the purpose of the cardiopulmonary system for years, and it's mainly used during surgery to provide surgeons with a bloodless workspace and allowing for direct surgery on the heart, the lungs, and the surrounding coronary arteries. The first procedure of this kind was carried out by John Gibbon using a machine developed by IBM, which was later developed by John Kirkland from the Mayo Clinic, and this was all the way back in the 1950s. Components of any heart-lung machine include tubing, usually made out of silicon rubber or PVC, which is good for making contact with blood, a pump, which includes either roller pumps or centrifugal pumps with an alternating flow head, an oxygenator, either a bubble oxygenator or a membrane oxygenator, a heat exchanger, which keeps the blood warm, cannulae, which are sewn into the patient's body in multiple locations to remove venous blood, infuse arterial blood, and deliver the cardioplegia solution. This is only used in stopped heart surgeries, and it's a fluid solution designed to protect the heart by reducing the metabolic rate of the muscle, preventing cell death. It's delivered via cannula to either the opening of the coronary artery or to the cardiac veins. This involves inserting cannulas at the aortic root and coronary sinus, respectively. A high potassium ion concentration present decreases the membrane resting potential. As well as this, the heart is cooled to 15 to 20 degrees Celsius to further slow the metabolism and protect the heart during the stoppage process. The actual cannulation of the heart is different depending on the patient, and there are variable suitable locations used. Prior to use, the circuit of the heart-lung machine is primed with a fluid, expunging all the air already present. Heparin and anticoagulants are administered till the clotting time of blood is above 480 seconds to prevent blood clots developing within the machine or the patient. Also before the operation, cannula sites are thoroughly inspected using ultrasound, and especially the arterial site for any potential calcification that could occur. There are two main approaches for venous cannulation: cavo-atrial, which is a single incision in the right atrium at the narrow end of the inferior vena cava and at the proximal end in the right atrium, which takes blood from the superior vena cava and the coronary sinus, or bicaval, where the superior and inferior vena cavas are separately cannulated, sometimes through one incision, but more commonly in two, and is used if a completely bloodless heart is needed, especially in surgeries directly on the heart or right atrium. The cardioplegia cannulation for delivery of the cardioplegia fluid occurs in various locations: antegrade in the aorta between the heart and aortic cannulation site, or retrograde at the coronary sinus through the tricuspid valve, and sometimes both are used to cover the whole heart. The heart also needs something which is called venting. If the left ventricle has blood leaking back through the aorta, it can become distended, and if the aorta isn't clamped, that can exacerbate the problem. However, vents are placed to avoid this. These vent lines also help remove any air that leaks in to avoid emboli forming. ECMO, on the other hand, stands for extracorporeal membrane oxygenation, and is a form of life support that is offered to patients with the most severe forms of heart and lung failure. The technology for ECMO is largely derived from the technology from cardiopulmonary bypass, which is designed to provide shorter-term support with arrested native circulation, i.e. the heart and lungs are stopped. Generally, ECMO is used after cardiopulmonary bypass or in late-stage treatment for people with profound heart-lung failure. However, it's now being seen as a treatment for cardiac arrest in some places. ECMO is also used to support patients with COVID-19, especially in cases where artificial ventilation is not sufficient to sustain blood oxygenation levels. For more about COVID-19, check out some of our previous episodes on the channel. In ECMO, blood is pumped outside of your heart to a heart-lung machine that removes CO2 and sends oxygen-filled blood back to the tissues in the body. This method allows the blood to bypass the heart and lungs, just like in cardiopulmonary bypass. However, where this differs is that ECMO uses membrane oxygenators only, and is therefore seen as a more advanced form of oxygenating the body. There are several forms of ECMO. The two most common are VA, or veno-arterial ECMO, and VV, or veno-venous ECMO. In both modalities, blood is drained from the venous system and is oxygenated outside the body. In VA ECMO, the blood is returned to the arterial system, and in VV ECMO, the blood is returned to the venous system. This means in VV ECMO, no support for the heart is actually provided. Increasingly, ECMO has been trialled for use in intraoperative procedures, not just to help people recover after an operation. According to a study from the Journal of Thoracic and Cardiovascular Surgery back in November 2014, intraoperative use of ECMO for lung transplants was associated with lower transfusion requirements and less use of cell saver relative to cardiopulmonary bypass. And even after the operation, the ECMO group had less bleeding, had fewer reoperations, had to receive less plasma, and had less overall heart damage. In addition, ECMO has the benefit of having easy conversion to post-transplant cardiopulmonary support. There were, however, no statistically significant survival differences between the two groups at 30 days or a year later from their operations. Needless to say, the importance of both of these types of heart and lung support in surgery is unquestionable. They're used the world over and make many surgeries that are routinely carried out almost impossible without them. Now we're going to move on to Shrey, who's going to be talking about pacemakers and ICDs.
So a pacemaker is a small electrical device about the size of a matchbox, which weighs 20 to 50 grams depending on which one you have, although they are getting smaller with new models coming out. And what they do is they send electrical pulses to your heart to keep it beating regularly and make sure that it's not beating too slowly or too quickly. So usually in a healthy heart, the sinus node found in the top of the right atrium is your natural pacemaker. But if this is not working properly, then you'll have to get a pacemaker fitted to do the job for it. Fitting a pacemaker is very common. It's one of the most common types of heart surgery, with thousands of people getting it every year, and it's a regularly done procedure with very few side effects from it. And what the pacemaker consists of is a pulse generator, which emits the electrical impulses, and then that's sent through leads into your heart, which are implanted in your heart, which cause the heart to contract at the right speed. So the rate at which electrical impulses are sent is called the pacing rate. And most modern pacemakers work on demand, and this means that they're programmed to adjust the pacing rate in response to your body's needs. So, for example, if your heart is beating normally all by itself, it probably won't send a signal at all. But say that you want to suddenly start doing something active, maybe you're getting up, walking, running, whatever, it will have a rate response, which means that the sensor inside it will detect your body movement and the increased breathing rate, and it will speed up the pacing rate to make sure that enough blood is getting to your muscles. To fit the pacemaker is a simple procedure, about 1 to 2 hours. It's done with local anesthetics, so the patient is still awake as the pacemaker is being fitted, but obviously they're highly sedated to make sure that there's no pain and they're not in distress. And it's inserted under the skin near your collarbone on the left side of your chest. And there's a small incision there, and then they put it in underneath that, under the skin, and then they will implant the leads into your heart. People who have pacemakers are those where the sinus node isn't working. So, for example, if you have arrhythmia, which is infrequent heartbeats when your heart isn't beating properly, if you have heart failure, or if you have heart block, which is where the signals from the sinus nodes are not reaching the cardiac muscles, and so it's not contracting properly. And you could also have it if you have bradycardia, which is when it's slow, when your heart is beating too slowly, and also when you have tachycardia, which is when your heart is beating too fast, and both of them are bad. And new research for pacemakers is coming out, and there's a trial going on for a pill-size pacemaker, which is much smaller, which is wireless, so it doesn't need the leads. It just uses electrodes to cause the impulses, and it's implanted directly into the heart rather than in the chest, and it's thought to be better and less invasive, but that will still be for a couple of years, I think. Another similar device is an implantable cardioverter defibrillator, and this is shortened to ICD. It's similar to a pacemaker, but it, instead of giving consistent signals, what it does is if it detects that your heart is failing or something's wrong with your heart rate, it will send a large electric shock into your heart, and this reboots your heart to bring it back to a normal rate. And it's given to people who doctors think are at risk from heart attacks and heart failure, to make sure that in the event that happens, they can restart the heart using the ICD. So we've talked about pacemakers and ICDs, and now Adrian's going to talk about VADs and artificial hearts.
Now I'm going to be talking about ventricular assist devices and artificial hearts. The ventricles are the two lower chambers of the heart and are the most muscular. The right is responsible for pumping blood to the lungs to be oxygenated, and the left is responsible for pumping blood to the rest of the body to deliver oxygen, glucose, and other vital substances to every cell. Often it is the left ventricle that is weakened such that it is unable to pump with sufficient force to deliver blood around the body. This may lead to breathlessness and reduced physical ability, for the cells in the body have a reduced supply of oxygen and glucose, prompting faster breathing to increase the oxygen content of the blood, despite this not being a problem. A weakened left ventricle can occur from several different preliminary conditions, including a heart attack, specifically a myocardial infarction, which is a type of heart attack in which part or all of the heart muscle dies, or myocarditis, which is an attack of the heart tissue by a virus so that the muscle tissue is weakened. A left ventricular assist device may be used as a temporary solution in heart failure patients as they wait for a suitable donor. Donors for heart transplants are exceedingly rare. They must be both in good health but also dead. Most often, donations come from those who have died suddenly, for a motor accident, for example. With increased strictness on driver safety and seatbelt laws, fatal motor accidents have decreased, and so the number of donors for healthy hearts has decreased. As technology has become cheaper and more reliable, left ventricular assist devices have become more common as providing a bridge to recovery for patients suffering from heart failure. This is because the use of a left ventricular assist device allows for the steady blood flow through the patient's body while they wait for a suitable donor heart to be located. A left ventricular assist device is reliant on battery power that allows for the patient to resume an almost normal style of life. Batteries last for 4 to 6 hours at a time, and alarm systems are in place to let the person know should the batteries need changing. There is an additional battery that is always connected to the controller, and backup circuitry is present should the original fail. Everyone is given a portable car charger too when they leave the hospital, so that they can plug the charger into the car so the battery can be recharged during long journeys. A left ventricular assist device is useful when a part of the heart is weakened and needs support, but it remains a technological challenge to build an artificial device that can mimic the pulsative activity of the heart, and indeed the circulation of many organisms in the world. A pulsing contraption would require connections to a noisy compressor, and it is extremely difficult to construct a device with enough structural integrity to withstand the pulsatile nature of its contraction. Manufacturing a metal and plastic heart capable of beating that way for more than 18 months has so far proved impossible. Building a heart that mimics nature's love dove may be as short-sighted as Leonardo da Vinci's concept for a flying machine with flapping wings. Scientists needed to think more openly, to think in a way that did not restrict them to the way nature works. A result of this open, out-of-the-box thinking is an artificial heart without a pulse. The dire need for an effective artificial heart is what drove the development of the pulseless heart. Should a heart stop due to complete heart failure, there is nothing a doctor can do should the heart not respond to defibrillation efforts. A surgeon can carry out manual heart massage, but this is not a permanent fix. So long as the surgeon keeps up with the manual heart massage, the patient will live. However, this is not possible, and external pumping machines are scarce and expensive, and so some patients will unfortunately die. A pulseless heart delivers a constant stream of blood around the body, spinning at around 5 to 10,000 rotations per minute in the heart, powered by an external battery pack. Overnight, the patient is required to plug into the mains, and this creates a problem of infection, for every entry and exit point to the body poses a chance of infection. The skull is an area of the body with relatively little muscle and tissue, and thus has the lowest risk of infection for an exit cord providing power to the pump. This type of heart removes all the traditional means of determining whether a person is alive or not. There is no pulse to be felt or heard. If a doctor is to hear the chest of a pulseless patient, they are met with a steady whirring, not the familiar lub-dub sound that they are used to. And if the person was to have an ECG scan, it would be just a flat line. There was once a case that, due to the novelty of this technology, a paramedic once moved a pulseless patient to the morgue, declared dead, for they heard no pulse at the scene. A pulseless heart can be in the form of an LVAD, but it also can be used to completely take over the entire heart. In many cases, the heart muscle has not yet failed, but is rather weakened by viral infection, and the use of such device can allow time for the heart muscle to relax and recover, to the point where the artificial heart may be completely removed. Now, I'll hand over to Surya, who will be talking about why new technologies are not being adopted faster.
Now that we've looked at different types of technology to deal with heart disease, let us look at some of the reasons why these technologies are not being as widely adopted as expected. First, let's look at ECMO, which Anupam has discussed. ECMO is not as widely used as expected because of the high risks involved in the procedure. For example, bleeding affects 50% of ECMO patients, and in some cases, this can be life-threatening. The risk of bleeding is a result of the use of anticoagulants in ECMO. People who are recommended ECMO therapy are usually very sick and are already at high risk of complications. ECMO may not circulate enough blood to the kidneys, and so there is a risk of kidney failure as well. Bacterial infections are also a large risk, and the risk of clots developing can result in strokes or pulmonary embolisms. Another reason why ECMO is not extremely widely adopted is because it is an extremely invasive procedure, owing to the fact it essentially takes over the role of your heart. The availability of ECMO treatments can also be limited because it requires a very specialized team with highly specialized equipment as well. Overall, the limitation of ECMO is that in some cases, the risks can outweigh the benefits provided. Now let's look at pacemakers, which Ray has discussed. The limitations of the use of pacemakers comes largely down to the risks involved in the surgical installation of the pacemaker. For example, risks include an allergic reaction to the anesthesia used during the surgery, bruising, bleeding, and infection. Life-threatening complications are rare, and most of the complications are temporary. Similarly, implantable cardioverter defibrillators also have similar risk factors, which include bleeding, infection, as well as pneumothorax. But similar to ECMO, pacemakers and ICDs are limited by their risks compared to their benefit. Next, let's look at ventricular assist devices, which Adrian has discussed. As blood moves through VADs, blood clots can form, and so there is an increased risk of stroke or heart attack. To reduce this risk, patients are usually prescribed anticoagulants, such as warfarin. These can increase chances of bleeding, and since implanting VADs requires open heart surgery, this further increases the chances of bleeding. The blood could enter the gastrointestinal tract or the brain, which could introduce further complications. The power source and control units for the VAD are located outside the body and are connected through a port in the skin. And this naturally presents a risk of bacterial infection. There's also a chance that the device might malfunction and the pumping action might not work properly as a result. All these risks can outweigh the benefits of the surgery in most cases, leading to their limited use. So we have seen that technologies that help to treat heart disease are mainly limited due to the fact that they have many risks that outweigh the benefits provided by the treatment or procedure. But one other limitation is the budget of the NHS when compared to the high cost of these procedures. For example, based on US statistics, an ECMO patient can cost a hospital over $210,000, and an artificial heart can cost anything in the range of $100,000 to $300,000 per patient in the initial year. The cost for the artificial heart includes many aspects, such as the surgical cost, the actual device itself, and the cost of surveillance after the procedure. Given the high cost of these technologies, it is unviable to use this technology on all patients with heart problems. Overall, for the time being, these treatments can only be used on patients where the benefits of the treatment outweigh any risks. And now back to Adrian.
And so, with that, we have covered the basics of technology in heart disease, which is an exciting, prospering field of treatment. There are so many new technologies that can be used in the treatment of the heart, but the problem of money is still significant, and that limits its use today. Thank you for listening. Be sure to subscribe, leave a comment down below, and like the video for more content like this.